this water, is it from us or
It's for
it's okay. It's okay. Yeah. Okay. But I think I can confirm you here. You can move. I just wanted to check this. I'm sorry. It should be something. Yeah, it doesn't. Hello? Hello, hello? Do you hear me? Yes, this time today. The person is here. Hello? But here, because the microphones are there on camera. Can I ask a question? Yes, can you ask a question? What would you like to know, Joy Monty? I would like to know, Mother Rita, when will you present an actual presenter for the lecture series? You just been presenting other people, but when will we have a chance to present you? Present me? Yes. Then for that I would have to present. Exactly. So when are you presenting? I don't think. Why? Can you hear what we are talking about? Okay, nice.
Thank you.
Mic check 1, 2, 3. Check 1, 2, 3, 4. Is it on? Is it on? Is it on? Can you check? Check the mic check, mic check 1, 2, 3. And was really cool to start like being more active, like there is some projects such this one is amazing to join. So I get I can put the sound more. It's okay like this? No, it's loud. It's very smooth. Wow. Send me the link, please. Yeah.
Hello. Do you need help?
Oh, yes, please.
Hi. Oh, hi. Hi, guys.
Great. I had to go to the depot.
Oh. Yeah. I remember you saying, yeah. It was nice to meet you. Yeah, it was good. Yeah, it was all worked very well. Door-to-door service. Yeah. Okay, good. Cool. Yeah. That's yes.
Is it?
Yeah. Oh, hi.
Last time it was 1 hour.
Okay. Good. I have no idea if it's going to be less or more, but if it's more, at least feel free to make
That was very flexible.
Okay. Hi, Margarita. How are you doing? Yeah, nice. Yeah. It's nice to put faces to all the names.
All the names.
Yeah. That's fine. Yeah. All right. Yeah. So, many students.
Yes, I mean, I invited my department, of course. Yeah. Several times, I can remember.
Yeah.
And the live streaming is
Okay. Yeah.
so maybe you, that's one. We also count on watch live stream. Yeah, you can say online. Yeah, actually it says online, but you so you can see. Okay, we have one person. So it's days online.
so you can also use it later on. Send people a link.
Must be joking.
No.
You haven't seen me lecture yet.
I don't. I know I have work.
Yeah, yeah. Probably the first one.
Hi.
Hi. That's right. Yeah. Yeah, it's fine, thanks. Yeah, it's good. So, yeah, that's true. Yeah, thanks for
Here. That's
the invitation. Yeah, sorry.
Height short object is the type of
No, it's not.
you're right.
Yeah.
Maybe there's one of them should be.
Yeah, this is 3 0. This one.
there is the normal series of
But I don't know which one is this.
Okay.
Yeah.
That's really good. Das ist mein Zeitthema.
Ja, genau, ich habe schon versucht.
Duplicate.
Yeah.
Und dann geht der raus.
Aber mach eins raus. Mach da eins raus.
Yeah, that's
Das
good.
machst du.
That's good.
All according to
Yeah.
Disconnect.
yeah. Bridges.
Those.
If I know
But maybe if you don't figure it out, you better just there.
Yeah.
Sure. I'll just keep going much.
And then we
Yeah, I mean,
we drop the presentation from here.
Yeah.
Yes.
it's not.
You must be. Yeah. There you go.
So I'll just use this, yeah.
I don't know what's sorry, it's equal to
We have here a pointer. Yeah, if you want just to point. I was searching at that commission.
Then we're fine.
But I don't know, do you move the ones? No?
No,
Stay.
Yeah.
Stay all the ones.
Yeah. If I'm wandering around, also see,
it's pretty
No, you can move however you want. What do you think is my favorite?
So very close to this.
Yeah. I was almost covered. Okay.
Yes. It's not hard. Something.
It's really CT. What should we study?
Give them another one. If you're in the UK, you cry. The rest of you you're getting joy. I think it's library dogs. It's the
Okay, welcome everyone. Thanks for tuning in virtually. Welcome to the Global Health Lecture Series for today. And as you already heard, this time we linked the session together with the Migration and Health initiative or project co-organized with the Institute of Public Health and the Department of General Practice and Health Science Research. And I welcome Professor Bayard from the London School of Hygiene and Tropical Medicine, who will give a lecture on strengthening health system, health sector responses to humanitarian crisis and forced migration. And we're relatively very proud to have you here. And want to introduce to you a few points about Bayard. Bayard is a professor of health systems and policy at the London School of Hygiene and Tropical Medicine. He has a public health background, mostly related to armed conflict, forced migration, and health, with a specific focus on mental health, non-communicable diseases, and harmful health behaviors. He's currently leading a large program which seeks to support decision-making in humanitarian responses. A mental health intervention study with Syrian refugees, also in Germany. And working with Médecins Sans Frontières, Doctors Without Borders, and evaluators basically their NCD services. Bayard is editor-in-chief of the Journal of Public Health, which is, I would say, a must-read for anyone who's actually interested in these kind of topics related to humanitarian issues and science. Not only humanitarian issues, but also link between humanitarian crisis and science. And he has taught on the subject of conflict and health at the London School of Hygiene and Tropical Medicine, at King's College London, Imperial College London, and the World Health Organization. So the floor is yours.
Thank you very much, and thank you to various organisers for inviting me here and for the organisation. And extremely generous of you to provide some London weather for me. We're very at home here. So, most of my time working at the London School and prior to that, a lot of the research that I've been doing is related to forced migration and armed conflict. And we're very conscious of the fact that there's lots more that needs to be done in terms of generating evidence and research to inform practice, but also some of the failures in using research and evidence and turning that into practice. And so that's really been a lot of the focus of our recent work, and particularly through a recent Lancet series that me and a colleague led on, and a project that I'll mention later on. Because there remain huge gaps in practice in humanitarian response. In a sense, it's a relatively new industry. And it's, there's some amazing work that goes on, but of course there's still lots of progress that can be done. And so that's what we're trying to do, and including how the academic sector can do a lot more in this area of work. What I'd like to do is firstly give just a very brief background on humanitarian crises and accountability. I'm sure you're extremely familiar with work around humanitarian crises and typical forced migration. And then I want to explore some of the weaknesses in the accountability, the work on accountability, focusing just on health, particularly health sector performance. And then I'm going to focus on looking at how we can strengthen the humanitarian response. Being a good academic, I spent most of the presentation just complaining, basically, and highlighting in the humanitarian sector. And then there's 3 slides at the end trying to provide some recommendations. So just fulfilling all the stereotypes of routine academics. Making no regret contribution whatsoever. Right. So background. This is a standard definition of humanitarian crises. They involve both armed conflict, but also natural disasters, famines, and also major epidemic outbreaks such as we saw in West Africa and Ebola. For today's session, and most of my work has really been around armed conflict and forced migration, so that's what I'm going to draw on in the presentation today. And I'm focusing on civilians rather than armed combatants, and also focusing on those civilians in low middle income countries, because that's still where the vast majority of conflict-affected populations and forcibly displaced populations live. And so what we've seen is well, you here in Germany can be more familiar than almost everyone, a huge rise in the numbers of conflict-affected populations, particularly refugees. And recently, it's largely as a result of the crisis in Syria, as well as a number of other crises, particularly around the Middle East and Sahel region. And what it's really dominated by is these orange bars, which are internally displaced persons. So we essentially see around twice as many internally displaced persons as refugees. Inevitably, it's refugees that have received a lot of the attention globally, and historically that's always been the case. And it's clearly the refugee crisis in Europe that's led to a lot of renewed interest in the issue of armed conflict and forced migration. But a really neglected population are the internally displaced persons. And we've also seen a related increase in aid funding going into humanitarian response. So it's up to around sort of $15 billion a year now in all sectors, not just health. And so financially, it's a huge industry. And some crucial things to bear in mind when we're talking about certainly both refugees and IDPs, as internally displaced persons commonly referred to, is the longevity of displacement. It's I'm not sure how accurate it is, but the standards for time length given for refugee displacement is something like 17 years. So it's years, not months, and internally displaced persons are commonly similar time periods. So you really have to be thinking beyond just sort of acute emergency response and the health sector response to them. And increasingly, refugees and IDPs are displaced to city-urban situations. So it's not really a traditional iconic camp situation that humanitarian agencies are really responding to so much now. The majority are now displaced in urban settings, which presents lots of opportunities for them, but also potential challenges, particularly for aid agencies and how they respond. And in terms of health outcomes, this is a fairly dry figure of what is clearly a hugely emotive subject. But the ultimate outcome of interest for humanitarian agencies in understanding health needs of the population is mortality. And here we've got different death rate ratios, which is essentially the rate ratio compared to the baseline prior to the crisis or prior to the displacement. And what this is showing is that internally displaced persons generally have much higher mortality compared to baseline than refugees, which is essentially hovering around the levels of they would have experienced, mortality rates experienced prior to the displacement, which is what you would expect. Once the humanitarian system is kicked in, you would expect that mortality rates would, after certain elevation, come back down to baseline levels. So that suggests that something is working within the humanitarian system. The problem is for IDPs, it's almost twice as bad as it was. And this can be for very sustained periods. So there's huge challenges, particularly in internally displaced persons. What we also see challenges are what's called here as resident populations, or also known as sort of entrapped populations. So those are populations affected by conflict that have not been displaced. And in many of those are the hardest to reach for obvious reasons, certainly compared to refugees. And so we've seen sort of significant elevated mortality rates amongst those populations. So in all the attention focused on refugees, and to a lesser extent IDPs, we always have to bear in mind the huge impact that it has on people that have not been displaced but still remain within the sphere of conflict. And obviously it goes way beyond mortality as the major outcome, with huge suffering in terms of mental and psychosocial health, poor sexual reproductive health, sexual and gender-based violence, and really catastrophic impacts on health systems. So what we're seeing is an increasing trend of directly targeting health facilities and health workers in conflicts, obviously ones being in Syria, but also seeing it in Yemen, also saw it in Ukraine. These are principally sort of attacks led by government forces in Syria with Russian support. And so that's become perhaps a more visible characteristic of war. Rather than health practices being protected under the Geneva Conventions and humanitarian law, they're now deliberately being targeted and having to take away the Red Cross symbol or Red Crescent symbol because they would have been targeted for it. And we also see knock-on effects for health systems, not just the destruction of health facilities or health workers, but also the collapse of key public health and health system functions, ranging from financing, supplies, medical supplies, surveillance, and so on. So we see outbreaks of diseases that had previously been curtailed. We also see challenges in accessing care for people, particularly people with chronic conditions, and this has become a real emerging issue as a result of the conflicts in the Middle East, where the disease burden is dominated by non-communicable diseases. So people are no longer able to necessarily access the same care or treatment they were receiving before, which is life-saving or life-sustaining treatment. And the challenge for the humanitarian community is that the whole system is essentially predicated on meeting health needs in sub-Saharan African parts of Asia, where the concerns around disease outbreak, malnutrition, and averting childhood deaths. And what we're seeing now, because of changing global demographic epidemiological transitions, as well as the nexus of conflicts in the Middle East, is that the disease burden is dominated by non-communicable diseases, which poses new challenge to the system, which at the moment it's not really responding to adequately. As well as it being extremely expensive. To roll out a measles campaign is not expensive, but to provide care for cardiovascular disease, cancers, and so on is. So it poses huge challenges to the aid agencies, particularly in the Syria response in the countries surrounding Syria. So moving on to accountability, this is probably the sort of leading definition of humanitarian accountability. What I don't want to do today is get caught up in discussion around what is the meaning of accountability or the plethora of different definitions of accountability or whether it's a good thing and so on. Intrinsically, I feel it is. This definition is the most wide-ranging one. And it really kind of represents this culmination of what's been called an accountability revolution in humanitarian response, where we've seen this kind of explosion of guidelines and work around accountability, largely in response to recognition of the fairly huge failures in high-profile humanitarian responses, such as Rwanda, Darfur, Haiti, and so on. And recognition that it needs to be strengthened. And that is both, traditionally it focused very much on accountability to donors, so the NGOs as the frontline providers being accountable to donors for the funding and the activities that they provided. Then it moved on to being more accountable to the individuals and communities that those NGOs sought to serve. And it's summarised in these kind of 9 commitments in this core humanitarian standard on quality and accountability. And this is probably the leading guidance on humanitarian accountability. Most of the leading NGOs have signed up to it. Sphere standards and other leading standards have sort of been involved in its development. And it kind of covers all things to all people, and that's the strength of accountability, the potential, also the weakness, because it's so all-encompassing. These are areas that I'm going to focus on today. That's not because I think they're more important than the other areas. Clearly they're not. They're all interlinked and each are equally important. I'm principally focusing on them because it's kind of what I do and what my colleagues have done, and relates most closely, I think, to the way in which the health sector is performing in humanitarian response. So it's really about questions about the effectiveness, the efficiency, the timeliness and relevance of health sector responses to humanitarian crises. So that's what I'm going to focus on today. So moving on to some of the weaknesses in accountability. So this really, I'm going to give 2 examples of work that we've done to try and highlight some of the gaps and the weaknesses in health sector responses in humanitarian crises. And this is work that, as I say, me and his colleague Francesco Checchi did when we led this Lancet series that we launched in June. Frankly, it took so long. We should have been utterly ashamed of how we counted for its delayed appearance. But a lot of the work focuses is asking these questions around core elements within those 9 humanitarian standards around effectiveness, efficiency, and timeliness of humanitarian response. So the first paper in that series, and the first of these 2 examples I'm going to go into, was a systematic literature review that we did on the evidence on the effectiveness of public health interventions in humanitarian crises. And it was a bit of an ambitious piece of work. It was commissioned by BFID in the UK and the Wellcome Trust in the UK. And it was a huge piece of work to try and look at where are the gaps in the evidence base on public health interventions in humanitarian crises. But we tried to apply standard systematic review methodologies using the standard databases. These are our eligibility criteria. So we're only interested in quantitative studies because we're interested in effectiveness and changes in health outcomes as a result of interventions. We went back as far as 1980. We used both published and grey literature. And then we applied these quality criteria. So the aim is not to look at how effective are interventions, it's to look at where are the gaps in the current work on effectiveness. And so the ultimate number of studies that we found was 345 studies. So this is globally since 1980. So we looked at all humanitarian crises in low and middle income countries since 1980, and these are the number of eligible studies that we found. And predictably, there's much more communicable disease and nutrition, and generally the quality of those studies was good. But there were some real sort of omissions, I think, in the evidence base. So if we look at SRH here, sexual and reproductive health, I think it was around sort of 15, 16 studies or something since 1980 have actually sought to look at are sexual and reproductive health interventions leading to better health outcomes? Are they measuring those health outcomes? There are some caveats to all of this, and we'll come to that. So it's not many. And the problem, to give an example of sexual and reproductive health interventions, is that a lot of the studies, the quality was poor, and they massively overreached in their claims of what the intervention had achieved. So they were sort of trying to show attribution where it's impossible to prove that. And this is problematic because if NGOs who are often involved in these studies with academics are claiming effects where it's not possible to have an effect or to be able to demonstrate an effect. We don't know if that intervention is actually working or not, it's been showing that. But we've got here NCDs, there are 8 studies on NCDs, reflecting the fact that they're new to the humanitarian system. It's still weak. But even something like mental health and psychosocial support, there are quite a lot of studies, which is great, and actually a lot of very good quality studies. Where the big gaps were in something like psychosocial health. So there's huge interest in psychosocial health and getting away from a narrow definition of mental health, focusing only on particular disorders like post-traumatic stress disorder, very narrow interventions or use of psychotropic drugs, to take a more holistic approach based on a sort of broader notion around psychosocial well-being. The problem is that there are hardly any studies that are looking at the effectiveness of psychosocial interventions. So there's huge money going into this field. Do we know whether it works? Based on this evidence, not really. So it raises some fairly fundamental questions about, is what we're doing in humanitarian crises working in certain sectors? And this is a slide of the same health outcomes, but looking at the quality of them. And what we saw is really that the quality was fairly minimal in most cases, apart from communicable disease and WASH. But remember, there are only 6 studies in WASH, that's water and sanitation. So we're seeing a sort of limited quality of studies as well. And we'll come on to some, clearly there are many challenges to trying to do studies, and intervention studies in these settings. But it is problematic. Another key issue was really around the economics of all this. And so we know that there's never enough money to go around in humanitarian crises. So when you have appeals from coordinated appeals from the NGOs and UN agencies, they're commonly funded at about 30–40%. Money is short, and so we need to make the best use of that money. And the use of cost effectiveness is clearly a very useful way of maximising the use of these limited resources. The problem is that out of these 345 studies, only 10 of them looked at anything related to costings of the interventions. I think it was only 4 of those 10 looked at cost effectiveness. So we've got major gaps there. You know, most of our other sectors that we work in, certainly in Germany and the UK, it's impossible to conceive of this multi-billion-pound industry with virtually nothing around the cost effectiveness of what's going into it. So there's huge opportunities there for greater efficiencies in this system. Now, there are some obvious caveats for that review. There are obviously, looking at health outcomes is not the only way of knowing whether activities are effective, and there can be proxy outcomes that can be used, for instance, access to delivery care as a proxy for maternal mortality. A number of these interventions have well proven effectiveness in other settings or more stable settings, and it's plausible to think that that will equally translate to humanitarian crises. Another reason may be that actually a lot of the agencies, particularly NGOs as the principal providers of care in settings, are doing this research. Certainly they're collecting data on costs, but they're not sharing it, which raises some further questions around transparency and accountability. There are other types of reports. We were only interested in intervention studies showing changes in outcomes, but there is interesting work done on modelling, including modelling of various different approaches to intervention. So we wouldn't pick those up in our review, but for example, DFID and UNICEF have done some recent work in that area. There may be some more recent work, studies that have been done. Clearly, there are other major sources of data that can show changes in outcome over time. So particularly routine data that one would hope could be used to show these changes. It may not be published in studies, but it may be able to demonstrate changes in outcomes as a result of some kind of intervention. And lastly, there are many other methods that are used to collect data to try and understand health needs and understand whether that intervention, that set of humanitarian services, is working. And so this has often been a criticism of this systematic view, certainly one that I would criticise it for, is that it's focusing on fairly academic, sort of rigorous studies, and it's not capturing the full range of routine data and routine data collection methods that are used in these crises. But another paper in our series did that. So this colleague, I wasn't involved in this, and I'm just plagiarising, copying their hard work. So this was led by Francesco, the other co-editor of the series, and essentially he was taking the opposite approach, was saying, hey, what are the key types of data that agencies should routinely be collecting as part of their mandate as humanitarian agencies? Most sign up to various standards, guidelines, and so on, and are part of what is known as the humanitarian cluster system, where they agree to follow certain procedures and reporting approaches and activities. And most of those agencies sign up to that. And so they're collecting, so Francesco and his colleagues wanted to look at how well are these agencies actually collecting this data. And so what they did is they looked at the first 6 months of major emerging conflicts since 2010. So the first 6 months, because that's the most important period in any crisis, because that's when you've got elevated mortality, morbidity, and risks, and harms associated with that conflict. And they used all this sort of standard growing literature sources, web-based sources, where these type of data should be placed. They also spoke with people involved in these humanitarian clusters and these different crises they've identified to find out whether these data have been collected and where they can be found. So it's a very comprehensive review, and certainly trying to get away from the traditional academic sort of fixation of published literature. And what they were doing, these are the types of information that they were looking for. And forgive the acronyms, it's another failing, I think, of the humanitarian system, that I complete obsession with acronyms. But we've got what's known as this 4W approach, which is essentially a coordination mapping approach of saying, where are agencies working, when are they going to be there, why are they there, what are they doing, and so on. And that's just to try and improve coordination of activities, because the classic criticism of NGOs was this overlap and duplication of work. So that was seen as a really important approach of the humanitarian system. And then we've got this thing called MIRA, which is a rapid assessment, so it's not applying strict quantitative methodologies, but it's to get rapid understanding of health needs and risks within a given population affected by a new crisis. Similarly with the HIRAMs. And then we've got a range of sources that are trying to collect key essential data on mortality, under 5 mortality, malnutrition, and measles coverage, because measles is always the big fear in these settings if that breaks out. And then also a communicable disease outbreak system, EWANS. And then finally looking at psychosocial assessments. So these are all seen as sort of essential data sources that should be collected. And then they looked at whether these have actually been implemented, how quickly have they been implemented, and the timescales here will vary from 24 hours to 14 days to 30 days to 2 months, depending on the type of information that's collected. And to what degree were they covering the affected population? So if we take an example of Syria, they looked at as many sources as they could, and they broke it up into 3 different categories: of government-controlled areas, opposition or contested areas, and then refugee populations in countries surrounding Syria. And what this is showing is the grey boxes here are essentially where they were unable to determine whether any data was collected at all. They couldn't find any on the web, but they couldn't find people to speak to confirm whether it had been collected or not. The red confirms that no data were collected for all these essential data types. The yellow-orange is where the data was collected, but it was incomplete. And then finally we've got green, which is yes, data was collected, and hopefully implement it in a timely fashion and cover the affected population that it's sought to. And so what we've got here, an example from Syria, is not a lot of green going on. And what they did is they then applied that to all these other major crises that took place in the last 5 years. And we kind of see it, maybe not quite as catastrophically bad, but a similar situation. But even if we could take something like Ukraine, dominated by red. Yemen, similar story. And so it's not, we know all the challenges of trying to work in these settings, and there are so many competing demands clearly. But this is pretty fundamental information to understand what the needs are, and then to be able to track that over time to know whether those needs are hopefully received as the humanitarian activities and interventions take place. So we've got kind of major challenges across all the significant conflicts over the last 5 years. If we summarise that, it's, again, we can see it's again, these are by the different information types. Not a huge amount of correct information collected. And if we look at that final column, the total column, less than 20% of all these crises, when summarised, have correct data collected. So in summary, the authors found that essentially humanitarian agencies are rarely collecting this essential information that's fundamentally a kind of mandated to. No crises have a full set of information that's available. And in most cases, it's really hard to access. So it's often hard to access for other agencies in that setting to get hold of it. And it's hard for others to get it in order to try and understand health needs or bring up issues around accountability. So fundamentally, it challenges this notion of accountability within some of the activities of these agencies. And as a caveat, or as a side point to this, it's not like we've got really fantastic guidelines that are helping agencies collect all the right data. So the SPHERE standards, I'm sure you're familiar with them, they're the leading guidelines and leading minimum set of standards that almost all humanitarian agencies, I think with the exception of MSF, adhere to and follow. The problem is that most of the indicators that can be used to measure success or otherwise of interventions are fundamentally not quantifiable or not evidence-based. Now, this was a fairly old study. There's sort of periodic updates of the SPHERE standards, and it's one coming up, I think, next year. So I hope things will improve. They're working hard to improve it, but it kind of shows some of the challenges that humanitarian agencies and others are up against. So when we come back to these humanitarian notion of humanitarian accountability and some of these core commitments, do we know whether it's appropriate and relevant? Often, how do we know that if we're not collecting the right data within these affected communities? Is it effective and timely? But again, we don't know that because it's not being routinely collected to look at changes. Certainly didn't seem to be getting done on a timely basis. Continual learning and improving, same story. Is it supporting staff to do their job effectively and fairly? Probably not, because they've got the information or resources to do it. Is it effective and efficient? How do we know? So there's some obvious reasons why agencies are struggling to collect this essential data. Most obviously, insecurity, the huge constraints on operational agencies being in the field to collect any kind of data. Logistical, political, financial, and time constraints, and the stress that is clearly individuals are under when they're working in these settings. There are sort of perhaps more anodyne, slightly less emotive reasons as well as clearly methodological challenges of trying to collect data, certainly collecting data on effectiveness in these settings, because there is no often baselines that are collected, or controls or counterfactuals. Movement is often missing And there's real challenges with showing attribution because there are so many activities going on in a given place. The chaos in many of these settings. How do you know whether it's your intervention that's had that effect? A fundamental challenge with all of this is also the approach of donors, where typical operational cycles are 6 months. So an NGO will get funding for 6 months. It's difficult for them to then think over the long term about creating long-term change. To start thinking about how can we set up systems that will allow us to show changes in health outcomes over time. So set up the data systems that are required for that. Again, there's very little funding actually for research or for meaningful monitoring evaluation in these settings. It's dominated by agencies collecting data on process indicators to be able to tell their donor what they've done. It's not dominated by funding to tell the donor what they've achieved in terms of improving health outcomes. And that's a fundamental gap in funding side. There's clearly limited technical capacity within agencies to be collecting some of the data, analysing some of the data, and being able to make decisions about how to use that data. There are ethical challenges with conducting research in these settings, but it's equally, I think, plausible to argue that it's equally unethical not to be collecting data in these settings. It could be argued it's public health negligence if agencies are not collecting and using data to improve their outcomes. There are clearly many faults from the academic side. I think academic engagement in humanitarian response has been limited. We have a different set of incentives for our career development. It's not necessarily based on doing good. It's how many papers you publish, how many research grants you get. So there are challenges there. And certainly the timescales that we have are very different to what an operational agency will have. And so there's really problems from our side. And I think we're also fairly awful communicating our research. We kind of think that we've written this nice paper that probably took 3 years to get published, by which time the crisis is clearly over. And then we think that it will automatically lead to better practice. And in fact, so we have to think much more clearly about how we can communicate our research in a much more timely manner and a much more effective manner. Shifting the blame back to humanitarians. There's been well documented sort of criticism around the culture of humanitarians, with one phrase being a sort of learning disabled. And it rather than necessarily being, trying to use data and evidence, it's much more based on experience and expertise, which of course is vital and are always probably going to be the sort of main approaches to decision making. But it includes a sort of reliance in a sense on the gut instinct. And some of those assumptions perhaps need to be challenged a bit more, and data may be a good way of doing that. There are problems with the notion of accountability. It's so wide. The term is so broad and wide that it means different things to different people within an agency, let alone between agencies. And often people can cherry pick the particular notion of accountability that's easier for them or their agency to deliver. And so there's a study by Tan von Schrie, probably mispronounced that, but anyway, that looked at all the different notions of accountability. They kind of did a systematic review around it. And the one that was looked at least was enforcement. And so there's this idea that accountability is great as long as you don't actually have to enforce it. So there's a gap there. And I think that there is, of course, people don't want to get bad news. They certainly don't want to get bad news if their funder may not continue their funding. So there's a sort of functionality to not collecting data, collecting certain types of data that may not impact on your future funding, or indeed the funder being able to get that money in the first place. And so it suits many people's interest to collect data on things that are not particularly measurable, that don't show changes in outcome. So, to the briefest part of the lecture, I'm going to strengthen accountability. Now, I've got 10 points here, stretched out to 10, but most of this is taken from the various papers in this last series. But predictably, strengthening the capacity to collect, analyze, and use necessary data. And that requires training of the frontline providers, in many cases frontline agencies, and working with NGOs, with local government officials and agencies, and trying to find, perhaps even having a cadre of workforce that can go out, collect data, check data, and work with agencies to get that data. I think there's a huge opportunity for developing performance metrics. So this is something that Francesca is going to be leading on in this project I'll come on to in a moment, around better ways of measuring performance that can almost act as proxies for outcomes. So focusing on quality, availability, and access, because all of these key elements are just missing in a lot of the current data, and certainly the guidelines that exist. We can do lots more with existing methods, most crudely bring in a bit of health economics to the sector. So economic evaluation, even if it's just costing out what it costs to provide a certain package or services of care, and including the opportunity cost of taking different decisions or approaches in different settings, because I think in many cases people just go with what they know, go with what's done in the past, without thinking, does that actually lead to worse outcomes? Or does the massive investment in one area because it's the fashionable thing now, what are the knock-on effects of that being funding that's taken away from other critical sectors or diseases or topics within that approach? There's fancy econometric and statistical methods that can get around some of these challenges around not necessarily having classic baselines or particularly control, so kind of make better use of routine data sources. And there are certainly ways in which we can improve our existing methods and challenge some of the methods. So even something as basic as a retrospective mortality survey, which is kind of rolled out in almost all crises, they haven't really been validated. We don't actually know how sensitive they are in collecting all the deaths that occur in that population. So there's some kind of potentially sort of basic problems or errors that are taking place with some of the methods used in these settings. And fundamentally, most agencies, a lot of them don't have digital systems in place. The data that is collected is never really shared at a cluster level with other agencies. And so it's almost impossible to know what's happening in a given population within a given sector or cluster, and why certain decisions made either at the NGO level or the cluster level. It's a kind of, we need to open up that black box. It's very untransparent. So for the second five, which are perhaps a bit more political in the sense of course, this all comes down to politics. That there is this shortfall in donor funding to collect data on quality standards and performance metrics. Everyone's always asking for more money. It's predictable. I think in the grander scheme of things, it's not a big ask. There needs to be there's a sort of a vacuum in a sense in technical leadership to collect such data and enforce the collection of such data in these settings. It should be WHO that lead this, but in most cases WHO are not in a position to do that. So who is it that is responsible for that? So there's governance questions around that. There should be some kind of penalty for agencies that are not able to report what the needs are in the population they've been mandated to look after, and what the effect is of their activities. At the moment, I don't know what penalties really exist. I mean, there are penalties for fraud, for example, but malpractice, not necessarily. Failure to collect, provide, failure to report this essential information, I don't think it's really there. I think it would be fairly easy to penalise agencies by basically withdrawing funding or withdrawing a mandate to be part of that humanitarian cluster and operate in those settings. So there are penalties that could exist. It's not going to make me very popular with the NGO partners that we work with, but there has to be some kind of penalty in place. It's this idea of enforcement of accountability that needs strengthening. And that agencies are held up for scrutiny, basically. I think finally there's an issue. I know that there's a danger in the public health academic of seeing these with technical solutions or technical fixes. Clearly they're not. It's politics that drives a lot of the decision making. I mean, politics, organisational politics, or local, national, global politics that drives the reasons why agencies take the decisions they do the activities they do. And I think that needs to be explored a lot more. And where is this interaction between data and evidence and the real world, and why do agencies make the decisions they do? And how can the use of data and evidence be strengthened? As I said, it's not, it's obviously not the strength of academics and how that can be done. But I think we could learn a lot more and investigate that a lot more. So I just want to give a quick final plug here to a project which it adds a little bit of hope at the end of all this moaning and complaining. In that it's an example of this is a project that I was awarded starting in October. It comes from the UK, it's dominated from the UK government. It's an £8 million project. We're working with various universities, including in Lebanon and Sierra Leone, but also with some leading humanitarian NGOs like MSF, International Rescue Committee, Save the Children, and BRAC. And it's got a whole range of activities that relate to some of these critical gaps in response. Building and training activities in them. And it's an example of an academic and NGO partnership where hopefully we will be able to offer some contribution to the sector. Also learn from the academics about what their needs are, where the evidence fits and where it's useful. Clearly these NGO partners have an appetite trying to make more use of data to inform their decision making. So in summary, what's required overall is improved governance in the health sector, in humanitarian crises. This really requires an interagency initiative. It's not enough to limit it to individual agencies alone to try and improve. And it does require far greater investment. I think it's that slide at the beginning showed around 15 billion or something for aid against humanitarian response. I can't remember what the health amount is in like 2 or 3 billion or something. The impact of conflict and violence globally is going to be something like 14 trillion. I don't think it would cost more than 100 or 200 million to set up a kind of an intergovernmental agency of some kind to really work with these agencies to support the use of data and evidence, support understanding it better, support understanding the effectiveness, the timeliness of humanitarian response better, and where needed, hold agencies to account. So it's not a big ask in the grander scheme of things, and it's entirely doable. To colleagues such as Francesca and Hannah are seeking to do this, and we work with these agencies, discussions with WHO and others, it's possible to do. It's a minute drop, really, in the grander scheme of investment in these settings. And ultimately, I'm sure it will be very cost effective, as well as saving huge numbers of lives and improving lives. So I shall finish there, and thank you for your time and attention as I complained and moaned away. Thank you very much.
Thank you, Bayard, for this very interesting talk and presentation. Yes, we open the round for discussion. Questions.
Thank you very much for the possibility to hear about what happened with the humanitarian
Can you introduce yourself?
My name is Janina Piquera. I am working with MSF, Medicine Volunteer. I want to ask you first, when we are talking about humanitarian agencies, so what is the meaning? Because we have a big family, no? Inside of the humanitarian agency, we have UN agency, OCHA, we have the support of the WHO, we have a small humanitarian agency in the field, and we have a big Medicine Sans Frontières, Doctor Without Borders, Handicap International, Union Run. So,
Yeah.
please.
It's a very good question, and we know that there is this sort of concurrent explosion of NGOs in humanitarian crisis development more broadly. So there are literally thousands of NGOs. I think in my sights, in my mind, it was the major NGOs because they are still providing the vast amount of aid. So NSF, IRC. So there's a handful of the major NGOs that are still delivering the majority of care. So I think they are a key starting point. And so that's both international NGOs, but also national NGOs. So for example, we're working with a number of national NGOs. But also the UN agencies. I mentioned WHO a lot because it focuses on health. And they have a responsibility and a mandate to be leading the health globally, but also in humanitarian response. In most cases, they're leading this health cluster. And so they would be the logical agency to be involved in this, but also to hold them to account. I think the challenge is where you've got a lot of these smaller NGOs. So, for example, in the Syria response, we saw really important work being done by voluntary organisations of the Syrian diaspora working with Syrians in Syria to provide care. And that was essential because many of the international agencies and NGOs could not get access in those populations. But it's much harder to work with them because they can be hundreds. And they're not in a sense as organised as NGOs. And I think there are, so it's fundamentally UN agencies. I think the donor agencies have to be engaged with because they're the ones that are dictating the terms for most of the NGOs. So if they're not giving the funding to NGOs to do the research, do the monitoring evaluation, how can they? They're not giving the incentive to do it because they're giving them 6-month cycles. And it's interesting with MSF. I work with MSF in research, and I have huge respect for MSF because they have led the way in doing research in these settings, and they've shown that it's absolutely possible to do really groundbreaking research, high quality research in these settings, and they've changed the nature of a lot of policy in humanitarian settings through their research. And the interesting thing about MSF is obviously their funding is very different. They have much more independence, and they've taken that decision to be more focused on an evidence-based approach because they get that freedom. They're less dictated by donors. And I think there's a lot of lessons that we learn from MSF.
It's a very strong play for evidence-informed or evidence-based humanitarian responses as compared to the experience-based and, as you said, not based humanitarian response. Are there any further questions?
There is a bunch of the topics. So I was really interested to hear about the lack of data that was collected by agencies, but I'm also interested in it's great that agencies themselves are collecting data and looking at that data and strengthening that. I'm also interested in the translation of that data back to the governments and strengthening the health system post-conflict. And whether you looked at that at all, or whether that's a feature of the project.
Yeah, it's a good question. We didn't look at it because, in a sense, we were focusing on data, depending which bit of work. We're focusing on humanitarian crises rather than the long-term sort of post-conflict reconstruction and engagement for system strengthening. But my impression is that it wouldn't be shared much. I mean, the challenge of getting this data was pretty hard. I mean, certainly for that second set of data I was talking about. But it's unlikely that it's being shared with all the, the government agencies that matter. So I suspect it's not terribly used to inform decision making by governments per se, and certainly not in a post-conflict setting. I mean, it's a question of how useful it is in a post-conflict setting. I think the more critical issue is how much is it shared with government, local government, where appropriate in different settings. They can be marginal, so we should depending on the setting. But I suspect not very much.
Any further questions? Okay.
I agree with you that accountability is important. But coming from the field, especially in humanitarian crisis, what do you mean by accountability? Because there is a suffering. So who we need to account for? It's a beneficiary, the donors, or population. So there is no clarity on the accountability.
Yeah, it's in effect, it's all of the above. As I said, it's traditionally, a lot of it was focused on just being accountable to donors, and that was a fairly narrow sense of accountability of just telling them what you've done and reporting it financially in a fairly narrow process way. That has expanded to being accountable to the communities that these agencies seek to serve. I think the point I was getting is that there are lots of mechanisms now, some more successful than others, about incorporating communities in decision making by humanitarian agencies. I think that the concern that I have is that there's a danger that some of that's rhetorical, and also that it's a quick win. It's an easier win for some agencies to do than actually be able to demonstrate are they making a change in people's well-being, in the population well-being. So all of this work around effectiveness and efficiency and all that, ultimately that is geared towards the end, the beneficiaries, if you like, the affected populations. They're the ones that everyone should be seeking to help and assist. So that, in that sense, accountability should be towards them rather than necessarily to the donors.
I have a remark and a question. I think one of the very interesting parts of this lens that you apply is that you kind of go beyond the rather narrow focus on looking at individuals and individual diseases and problems. You look at the rather system level issue. I mean, health information systems are even in our reports very neglected, but then looking at information system in crisis situations is a very neglected issue. So this is a very strong part. But as you said, you raised many uncomfortable questions. And so my question is, have you presented this data to humanitarian agencies, and if yes, what is their reaction?
Yeah, I think we have. So when we launched this Lancet series, this was in London when we launched it, and the audience was full of NGOs, WHO came over from Geneva, and so on. For them, I think, partly we were keen on, so they knew what we were doing, and it wasn't. I don't take it. I hope it didn't come across like that. I'm not trying to shame agencies or their work. I have enormous respect for what they do, and I think most of these problems and these issues are kind of recognised by many people working within these agencies, and they're like-minded people. They want to do better, and so I think they weren't hugely surprised. And I'm sure there's also a sense of just an academic. It's easy for ivory panel academics to sit there in London complaining, why aren't you collecting more data in serious?
So these are different cultures also in terms of, is there an impression that this is just academic undertaking? I think that it is. I think it is essential. But from the other side, it's
yeah, I think there are problems with incentives and our different sort of ways of working, but I do think there's a lot of overlap. A lot of us have worked with NGOs, and there's a lot, we have some of us understand, the sense of what's required by NGOs. I think it's certainly potential to have common interest.
So currently, as you can also show in this weekend project, that there is common interest to further.
Yeah.
Any further questions? Yes.
I think it's a lot of former doctoral students here. So I have two questions, but both are basically related. So my first question is regarding the economical studies. There are, in my opinion, a lot of elements that are beyond any reach. So that would imply that possibly using more advanced economical tools would be able to overcome these barriers. But at the same time, that can be a paradox because that may scare also further the agencies to collect data and stuff like that. And so that was one question. Would you agree with that? And the second question is, how feasible would it be then to stop using economical metrics or econometrics and moving toward some alternatives, possibly qualitative indicators, something like that?
I think it's a good question. So the first one, so I think there certainly are methods that could be used, these sort of fancy econometric methods that could be used, and it's not going to be used by, some doctor or nurse in the front lines trying to save lives and then having to work this out. It could be that the agency is collecting this fairly so basic routine data, at an aggregate level, that could then be used by specialists, whether it's in universities or headquarter levels or whatever. So I think it's possible that it could be done that way. In a sense, the idea is that you're using these difficult techniques to overcome the problems with the data at the local level. So you're trying to make the most of this data rather than collect perfect data. You're using imperfect data, but turning it into something that's useful. So you only need one or two experts to do that. But I think that you also make a point that there is a danger of seeing this as some kind of panacea, saying not everything can be costed, and certainly not everything can be shown to be effective. I mean, the effectiveness is proven because it's hard to show attribution, and often the sort of long-term nature of these crises and the influences, it's not feasible to show straight away. So I think we have to be fully aware of the limits of data, and particularly data showing effectiveness and cost effectiveness. But I think there's still opportunities for that. The point you raised about qualitative methods, I'm glad you raised that, because I forgot to offer an apology in the lecture. But there's a kind of a bit of a bias towards quantitative methods here. Partly because we're trying to show, we were particularly interested in showing effective changes in outcomes. But many of the methods that we're showing as these rapid response methods bring in qualitative methods, and they are often far more suited to get a handle on the situation quickly. So there's absolutely a place for using qualitative methods, both in terms of rapid assessments, but clearly also a place in having a much more in-depth understanding of populations and their particular needs, cultural needs, and so on. But also understanding why interventions do and don't work. On a separate piece of work I'm involved with, it's looking at this study that was mentioned at the beginning. It's about mental health intervention for Syrian refugees. And the nice thing about that is it's a bunch of RCTs to look at the effectiveness of this intervention. But what we're also looking at is the potential for scaling up those interventions. So we're using qualitative methods to understand when these interventions take place, why they worked, why they didn't work, what the contextual influences that supported or impeded the implementation of that intervention and its effectiveness. And the two have to go hand in hand. And at the moment, the evidence base, for example, in mental health, on effectiveness, there's almost no qualitative studies that have been done in parallel or integrated with the quantitative studies. And it's not enough just to be able to say this works or doesn't work. We need to know why, and we need to know what can be done to support its expansion and scaling up. And to do that, we have to have a whole range of qualitative methods embedded within these intervention studies. There's definitely central to any work in this area should be qualitative methods.
Okay. Any further questions? Can't hold back with a remark, because basically, I mean, we have been looking now at income countries and conflicts. I'm sorry, but yeah, and conflict settings. But it would be really interesting and to parallel this with the view over here. We have learned 2 days ago here with Sabine Kleinert that Germany is such a resilient and developed health system, but we have done similar assessments in Germany in refugee settings, and there was a lot of red as well. So you start wondering what happens here. How come that in such developed health systems we have a similar or comparable lack of data? And the question is who's to penalize actually, or who is to become accountable here? I think one penalty that we faced already in 2015 was when there was the so-called refugee crisis, and the authorities were asked, okay, what are the needs, what is happening in terms of health, and no one could say anything, so this would fit into the shameful situation for everyone that needed to go to the public and was interviewed by cameras and public media, but I mean, there is no such publicity maybe in these content areas. But I think there is still a parallel, so I would not say that this is something that is happening out there and is not relevant for Europe. I would say, as you said, in the new report, there is a similar situation out of Europe.
Yeah, I think that's right. And I think it's, yeah, there are huge constraints in some of the low middle income settings, but there's also, in some sense, greater flexibility and freedom to develop alternative approaches, testing approaches, and methods. Whereas when you've got more established health systems, it's often more rigid and difficult to change. And so in the case of, for example, Syrian refugees here in Germany, access to care is much more difficult because it's better go through this formal system and understanding, not set up to meet the needs of potentially hundreds of thousands of people with very different needs to people on a volume. And it can be often slower to change the system. So it's, yeah, I think there's certainly lots we can learn both ways.
Okay, there are no further questions. Thanks a lot for being here for this very interesting talk and for coming to Heidelberg.
Yeah, thank you very much.
Maybe hand over to you, Albert. I'm not sure if this is the last lecture of this for this term. Maybe you have a few words or I'm not sure.
I am not a graduate, but I always work. Hello, no problem. Yeah. And I will just also notes this semester's global health lecture series. We may come up if something acute comes up. We'll still be something maybe in January. But for the planned lectures we are over, it was a very great experience. We were a bit, let me say, for various reasons, we had a very heavy November. There's not how you remember, so now basically we can all a bit relaxed, but maybe we will still think about an event digesting COP23 and the debate about climate change and health. So maybe still in January, or maybe we can do that in the summer semester. Also, if you have suggestions or if you have met some great people who you think we should invite for the summer semester, let us know. Yeah, so we are always watching. And then also many thanks. Yeah, that was a really great endpoint in a way. Yeah, so with the where we have basically had two times answers in a way. You were presenting the series, and we had the series on Germany. So I think it was a kind of week with a quite a number of highlights. Yeah, so, and this was highlight number 2. And with that, I thank you. Keep with us. Yeah, keep following up and keep coming and discussing with us and tell us what